Thank you. So occasionally patients are taken to the theatre and have a hepatectomy for suspected colorectal liver metastases, and then post-operative histology reveals that in fact they had an alternative pathology. Now this means unnecessary expense and loss of opportunity to treat other patients for us, and it means an unnecessary operation, stay in hospital, and risk of morbidity and mortality for the patient. It can also have long-term consequences for the patient. This gentleman previously underwent a right hepatectomy with excision of the middle hepatic vein for a centrally placed lesion, which turned out, in fact, to be hemangioma. He now has this biopsy-proven metastasis, which is pinching off the left hepatic vein. So very sadly, this man is now iatrogenically unresectable. So although unusual, this is an important phenomenon, and we wanted to look at it in some more detail. We took advantage of our Prospective database, which happily includes the referral diagnosis, and then divided our patients into those who had colorectal liver metastases, and also included with them those who appeared to have had a complete pathological response. And then Group B, the group we're interested in, those where, in fact, we had a misdiagnosis. We subjected these to univariate and multivariate analysis. There were 1,252 resections for colorectal liver metastases, of which 39, that's 3.1%, ended up in Group B. This slide shows the histology. I'll summarise it by saying that a quarter of these patients had an alternative malignancy, HCC, cholangio, some other form of metastasis. The others had benign pathology, of which, as you can see, hemangioma predominated. In this slide, we compare the groups to look for factors which may be associated with being in Group B. As one would expect, T-stage and end-stage, or also Duke stage of the primary, were significant, as were the number of tumours and the size of the largest tumour and the CEA level. We were surprised, however, that the synchronous or metachronous history didn't make a difference. I had assumed that in a metachronous case, the fact that the lesion had appeared, had grown, had behaved like a metastasis would give one some safety. I think the explanation for that is in this slide. There is a trend towards, in the metachronous group, the correct diagnosis being a malignant or inflammatory lesion, i.e. something which can also behave like a metastasis. We did a multivariate analysis. We used the Duke stage because we didn't have complete TNM staging on the primaries, and found that the CEA, the size of the largest tumour, and the Duke stage remained in the model. From this, we've developed a score to predict when patients may in fact have a misdiagnosis. And the score is performing really quite well, with an area under the curve of just under 0.9. You start with a score of 15. You increase if you had an early stage primary, and the score is decreased by a high CEA or by a large tumour. But to summarise what this is telling us, if your patient had a node-negative primary, has a small lesion in the liver, and doesn't have a raised CEA, then they may have a risk of misdiagnosis as much as 1 in 3. There are some limitations with our study. We only looked at cases that had actually undergone resection. There was some missing data, which we think is missing at random and therefore doesn't undermine the validity of what I'm saying here. And there were some characteristics of the primary, particularly the secretor status, which weren't available to us. We've used histological size and number as a surrogate for the radiological size and number, which obviously one would be using when making decisions. And I've only looked at cases where no lesion turned out to be a metastasis. Obviously, it's possible for one lesion to turn out to be a metastasis and another one not. In conclusion, then, patients really ought to be consented for the possibility of misdiagnosis at around 3.2%. That's of the same order as the chance of mortality after hepatectomy. standard practice that I'm sure everyone in the room follows at the moment of operating without biopsy is clearly justified. But there may be a group that we can identify in which further investigations or observations will be justified in some cases. We obviously need to validate this score, and I'm pleased to say we've identified a collaborator to do that, and eventually we'd like to have an online resource for this. Thank you very much.